Hi, good morning, everyone. Can you hear me?
Yes, bro.
Okay, all right. Good morning, everyone. I hope everyone is well and staying safe. My name is Darren Tay. I am a hip and knee surgeon from the Department of Orthopedics, Singapore General Hospital, and it gives me great pleasure to welcome all of you to our public webinar today. So today, the Department of Orthopedics has collaborated with the Patient Liaison Service Department to come up with a series of lectures. And hopefully this will be useful and informative to all of you. We'd like to thank all of you for logging on this Saturday morning, and also like to thank the Patient Liaison Department Office for their collaboration in running this public forum and webinar. In addition, this public forum today is actually part of a series of lectures and webinars that will be ongoing throughout the year, and we will have speakers from various specialties of our hospital who will come up with updates on their particular fields of interest. And if you're interested in attending those, there will be a link where you can subscribe to the mailing list. So for today, we will be talking on the advancements of hip and knee replacement surgery, and we really hope that you find it interesting and stimulating. I will give the first lecture, and that will be on robotics in joint replacement. How this robotic platform has helped our surgeons to perform better surgery, and how it has benefited the patients adopting this technology. Subsequently, we will have Associate Professor Pang Yini, who is our Director of Adult Reconstruction Service. And he will be talking on a very important topic called enhanced recovery following joint replacement surgery. And he will be sharing how our perioperative management has changed over the past few years, especially during the period of COVID, and how our changes have led to vast improvements in patient outcomes, especially with regards to earlier discharge and better return of function. And finally, we have Associate Professor Goh Xiao Kiet, who is our Deputy Head of Department, and he will be sharing on some memorable and interesting cases that he has come across and managed throughout his many years of clinical practice. So throughout this webinar, we hope you do find it interesting and stimulating, and we welcome all your queries and questions. And we encourage you all to use the chat function that is at the bottom of your screens. You can type in your questions, and we will try to answer your questions, either texting back to you through the chat function or at the Q&A session at the tail end of this forum. In conclusion, we really hope that we thank you for spending your Saturday mornings with us. We hope you find this useful. And at the end, we would appreciate any feedback that you have for us, what you found useful, and where you think we could improve moving forward. All right, so without further ado, I will share my screen and begin with my presentation. Okay, Brenda, can you see my my PowerPoint?
Yes, you can see it.
Okay, all right. So like I mentioned, I will be talking about robotic surgery in joint replacement. And so what is a joint replacement? Joint replacements are a very commonly performed surgery. And the reason why it is common is because we have many patients who come to us with painful joints. And the most common joints that we deal with are the hip joint and the knee joint. And as we will show, joint replacements are indeed a very effective surgical treatment for painful, advanced arthritic joints. All right, and arthritis means that the joint has undergone wear and tear, and the cartilage that used to protect the knee or the hip has thinned out or worn off, and now it causes great pain, dysfunction, and loss of quality of life for our patients. Now, routinely, when patients come to see us, joint replacement surgery is not usually offered as the first-line treatment. Generally, we will offer non-surgical options such as pain management, physiotherapy, weight loss programs, and hopefully some of these patients will benefit from conservative options and not require surgery. In the select subset of patients, those who are very active, those who are younger, we can even consider joint preserving surgeries where we don't replace the joints but try to realign the joints in order to preserve their native joint. This is increasing in popularity, but still the gold standard for advanced degenerate joint disease is the joint replacement. So I will just talk on osteoarthritis of the joint, all right? And this is a term that we will commonly hear. The other thing that sometimes people use as an alternative to this term is wear and tear, degeneration, rheumatism. So these are all sort of layman terms. The medical term is osteoarthritis, osteo being bone and arthritis referring to the joint. All right, and this is a disease. All right, so it is not really part and parcel of aging. All right, some people think that everybody eventually will get it, and certainly we recognize that advanced age is a risk factor for osteoarthritis, but it is not necessarily just part and parcel and where everybody will get it. So it is a disease. It is a chronic, slowly progressive degenerative joint disease that usually starts off at the cartilage, and then gradually it affects the bone, it affects the ligaments, it affects the muscles, and it causes impairment in function and quality of life. And as it stands, osteoarthritis is a leading cause of physical disability, not only in Singapore, but across the whole world. All right. And in Singapore, we see that 1 in 6 people above the age of 60 are afflicted by this condition. And as we age, this number can then increase to 1:5, 20-25% in the older age groups. And as a consequence of having this disease, if it's not managed well, it results in loss of function, quality of life, and economic productivity. So today we will be looking at some of the most commonly done joint replacements. So on your left, what you see is a partial knee replacement. So you can appreciate that it's a small piece of metal. The white pieces that you can see on the X-ray, these white things are all made of metal. And in between the metal parts is a piece of plastic that separates the metal, so the metal components don't grind on each other. And this is what we call a partial knee replacement because it only resurfaces part of the knee, as opposed to the one in the middle, which is a total knee replacement. And the total knee replacement is the most commonly performed joint replacement surgery in SGH. We do about 2,000 joint replacements of the knee a year and about 300 total hip replacements, which is what you can see on the most right-hand side. All right. So on the right-hand side, you can see this is an image of an X-ray of the pelvis. And this metal component here is a hip replacement, all right? So this is when you have degeneration of your hip, and the first 2 pictures are when you have degeneration of the knee. Now, the partial knee is done at a lower frequency because, number one, it is technically a bit more demanding, and number two, less patients are suitable for partial knee replacements. The patients that are suitable usually present a bit earlier and they have localized disease to only one part of the knee. However, when the arthritis spreads and affects the entire knee, then the most suitable surgery of choice for them is a total knee replacement. So how are joint replacements performed? All right, so during the surgery, we will expose the afflicted joint, be it the knee, the hip, and we also do shoulders and ankles and elbows. So we need to see the joint by cutting through the skin and the muscle and entering into the joint. All right. From there, we remove the damaged surfaces of the joint, and that would include the bone and the cartilage that has been diseased. All right. We remove them through the use of saw blades or burrs or reamers, and we prepare the bone surfaces to accept the metallic implants. All right. And the amount of bone that we remove is usually about the same as the amount of metal and plastic we put in. All right. So this removal of bone and cartilage creates a space in the joint. And then subsequently, we use metal and plastic components, which we select based on the size and shape of the patients. We install them and then we reconstruct the joint. And subsequent to the joint replacement, after the surgery is performed, then that comes to the most important part of the surgery, which is the rehabilitation. And that's where we really need the cooperation and the enthusiasm and the determination of the patients to help us get a good result. So what is a good result? What constitutes a successful joint replacement? When the surgery is done, the recovery is complete, and the rehabilitation has been given to the patient. What we would like to see is that the joint that we've replaced becomes pain-free. We've taken away the patient's original symptom. The joint is stable. It moves like a normal joint. It's able to bend and straighten like a normal joint. Patients like to be able to go back to their activities that they previously had been doing. We want to be able to fix the implants securely to the bone so that it lasts a very long time and patients don't have to come back for another surgery. And we want to do the surgery safely, free of complications. But it's not always so easy. And certainly in the 21st century, things are getting even more difficult. Number one, we have younger patients now coming in for surgery. We have heavier patients. We have patients who expect more from their surgery. They have greater demands. They want to go back to their sports and their hobbies and their occupation after the surgery. And a lot of our patients are living much, much longer lives thanks to proper diet, proper healthy lifestyles, and good medical care. And they are able to live way beyond the 80s and 90s and really challenge the implants that have been placed inside them. You can see on the picture, Mr. Chan, he is a local legend in the running community of Singapore. He has unfortunately recently passed away, but he was able to complete his 101st marathon at a ripe elderly age. So this just goes to show that there are many people who have great expectations and demands on their joints. In addition, we start to recognize that everybody's joints are a little bit different from each other, and there is a patient joint variability. So my knee joint and your knee joint will be completely different, all right? And in the old techniques that we used to do joint replacements, we sort of treated every joint about the same. The surgery was done in the same way, and we felt that perhaps by not appreciating the subtle variations or sometimes even very gross variations between patient to patient's joints structures, this could lead to patient dissatisfaction. And unfortunately, that's still one of the challenges that we face as surgeons today, that we are not able to make 100% of our patients satisfied. But I think we are getting there, and that's perhaps in part because we are increasingly getting aware that every joint amongst every patient is unique and different, and they should be treated accordingly. So joint replacements are increasingly not being performed like a cookie cutter, using everybody getting the same surgical targets. but we are tailoring them. We are creating bespoke plans for each individual patient based on their bony and soft tissue characteristics. So certainly, like I mentioned, rehabilitation and post-op care is very important to the success of a joint replacement. However, what we can do in surgery is to optimize it, to put it in the best position, to put the implants in the best position in the patient's joint, so that the patient, has able to return to function quickly, and the implants can last a long time. We want to avoid what is known as malposition. And malposition is where the implants are sort of put in a less optimal or incorrect position. All right. So how we prepare the bone surfaces determines how the implants will be installed, because the implants are placed flush against the bony surfaces. So depending on how much we cut and what angles we cut the bone, that will determine how these implants will sit. And we have seen that when you put in these implants incorrectly, they lead to residual discomfort following surgery. The patients sometimes complain of stiffness of the knee, that they can't really bend it as well as they could. Or on the other hand, sometimes it could become that the implants become loose and they are unstable, or they even can dislocate. And as a result of all these problems, they can lead to early failure, early loosening of the implants, and an increased revision surgical rate. So certainly we want to optimize the position of all these implants, be it in the hip, in the knee, in the shoulder, in the ankle, and that will position the implants for the best possible outcomes. So how do we go about it? Now, we surgeons are sort of restrained by the instruments that we have on hand, because we depend very heavily on the instruments that are available to us to do the surgery. Now, in the past, we used what we called conventional instruments, where they were very rudimentary, but very dependable instruments that were able to get the job done quickly and fairly predictably. But like patients want more, we surgeons also want more. And so when I look for better instruments, I would like to see an instrument, be it a computer that can help me, give me more data during the surgery, or robotics, which I'll talk a bit about after these slides. I would want the instrument to allow me to custom plan, all right, to set different targets for each of my patients, because as I said, each patient is different, each patient's joint is different, and we should have different targets for their different joints. Additionally, not only just planning, but I need my instrument to allow me to execute the plan accurately and precisely. So whatever I've planned to achieve, I want to be able to achieve it. Because there is no point in having the perfect plan, but executing it wrongly, right? Putting, executing, preparing the bone wrongly, and then finally installing the implant wrongly. And as a result of being able to execute the plans accurately and precisely, I want to see that these instruments allow me to have more consistent and reproducible results. I want the instruments to be safe and reliable, and so patients have less complications, and a faster recovery following surgery. So this brings me on to the role of robotics in joint replacement. All right. So why have we used robotics in joint replacement surgery? We've seen from many other industries, such as the manufacturing industries of cars, of computer chips, that there is proven track record of accuracy and reproducibility. All right. If we want to be precise, we really need the assistance of robotics to really become accurate to the millimeter, accurate to the degree. All right. That is something that, unfortunately, without the use of robotics, just using our conventional instruments, usually it is much, much more difficult. All right, and this technology, the use of robotics in joint replacement surgery, isn't new. In fact, we have been doing it for about 30 years already, and the technology has been improving year on year since the 1990s. And in the last decade, there has been an increased interest in robotics in joint replacement, with many of our orthopedic companies coming up with different variations of robots to help us perform the surgery better. And the reason for this increase in interest is that we are doing more of these surgeries today. The surgeries should be standardizable because of the high volume. We should be able to produce consistent results for our patients. And with conventional methods and conventional instruments, we do still see suboptimal outcomes, and we want to minimize this as far as we can. So what are the types of robotic systems that we have at our disposal in orthopedic surgery? They are basically classified onto what they do and how they do it during the joint replacement surgery. And we divide them into passive, semi-active, and active. All right, and I will show you what an active robot is. And this is a robot that we started to use since 2012 in SGH. All right, this is called the RoboDoc, and this was the first robotic system that we brought in. Now, that machine that you see on the right, it weighed 2 tons. So to bring it into our theaters, we had to actually get our engineers to reinforce the floor so it could take the weight of this robot. And this robot looks very similar to the robots that you can see in the other manufacturing industries. What you can notice at the end of this robot is a small little burr, all right? And this burr is the cutting instrument that removes the bone to prepare the bony surfaces. This robotic system is what we call an active robot because it moves by itself. It doesn't need the surgeon to actually move the burr. It has a predefined path and it removes the bone according to what we have planned prior to the surgery. So before the surgery, what we used to do is we go into the computer room, we would tell the engineers that we want to remove this amount of bone and we want to cut the bone at this particular angle. And the engineer creates a plan, a pathway, or like a GPS pathway for the robot. And the next day or the day after, we bring the robot in and it slowly burrs on its own accord autonomously and removes the bone for us. And once it's finished removing the bone, we then just put in the implants and we close up. Now, the problem with this particular robot and why we've moved on to newer versions of the robot was because there was a lack of intraoperative flexibility. And that means that during the surgery, if we wanted to adjust it, we were not able to. So it was kind of restrictive. And sometimes surgeons need to change their plans during surgery. And this unfortunately could not give us that flexibility. Currently, we have much better robots, all right? And they consist of 3 main parts. So you can see that there are 3 items on the screen. There is an eye, there is an arm, and there is a brain, all right? So on the left-hand most side, there is a camera system that actually can see where the robot is and can also see where the patient's joint is, be it the hip or the knee. All right, from there, it communicates with the arm, and the arm is where we attach the cutting instrument to the robotic arm. And we can attach different instruments. We can attach a burr, a saw, a reamer to perform different types of surgery. So this surgical robot is actually very clever. It's very versatile. It's almost like a Swiss Army blade, knife, and it can do different types of surgery. And finally, the most important difference is the brain. And that brain is where we can, during the surgery, put in new data into the computer, data that we can only capture during the surgery, such as the soft tissue laxity, like how loose or how tight the ligaments of the knee are, and we can refine our surgical plan. Plans that we made before the surgery, we touch up, we improve before we execute the plan. So that is the current day robotic assistance. And the way that it is done, there is an added level of safety. It is a semi-active robot now. So it's no longer active. Active means autonomous, the robot moves by itself. Nowadays, the robots require the surgeon to push and move the cutting instrument, all right? So that the robot doesn't move by itself, and we have full control of what the robot is doing at every point of time. Now, this robotic arm, so what does the robotic arm do if the surgeon is the one moving it? The robotic arm actually moves to the correct level of resection of bone, and it keeps the saw blade or the burr at the correct level so that we don't cut additional bone and we cannot go beyond the boundaries set by the robotic system, by the brain of the robot. And I'll show you a video later on how this particular robot provides an additional layer of safety because the saw blade cannot venture beyond the boundaries that are defined for it. So it cannot go beyond and end up accidentally cutting ligament, or worse still, cutting the arteries or the nerves. In addition, we now have numerous ways of collecting data to create a personalized plan for our patients. So every surgery that we use with every robotic surgery that we use for different patients usually have different plans. All right, so it isn't the same plan again and again for each and every patient. At the beginning of the robotic surgery, we capture information, and usually this is done through X-rays or a CT scan. And with the CT scan, we are able to generate a three-dimensional model of the knee or the hip. So you can see I've shown that the brain of the robotic system creates a three-dimensional model of the femur, and on this side, it's the tibia. And this is the exact same shape of the patient's knee. All right, this is unique to the patient with all the bone spurs and bone defects. It's all there. Subsequently, during the surgery, what the CT scan and the X-rays cannot provide us is the condition of the soft tissue, of the ligaments, of the muscles, and that is what we additionally collect during the surgery. And having these two sets of data, we combine them together and we create a personalized plan for that particular patient. And a personalized plan meaning that we want to then move that implant into the correct position that most suits that patient the best. And this allows for a balanced joint replacement consistently that remains stable yet flexible and minimizes the need for excessive soft tissue releases that can cause pain and slow down the recovery. And finally, having a good plan is really nothing unless we can carry it out precisely. And that's where the robotic arm comes in and allows us to carry out that plan with a high level of accuracy and precision, down to the millimeter, down to the degree. So I will show you a small video now of a partial knee replacement. And as I showed you in one of my early slides, a partial knee replacement is where we only resurface one part of the patient's knee. And the patients that are suitable for this procedure are those that have arthritis only in one part of the knee. Okay, so here you can see that the robotic arm, we've attached a burr, all right, a burr, and it will start spinning. And it will only spin when it's very near the bone, and it will only allow us to remove the bone that we have planned to remove. It will not allow us to take away any excess bone, and it will not allow that burr to, go beyond the boundaries of the bone where it potentially could injure soft tissue. All right, so I will just play this animation for you. So here you can see the burr going to a very small incision in the knee, and then it's removing the cartilage, and you can see that on the computer system, it actually shows us where that burr is in relation to the bone and what it's doing, how it's removing. You see all that green area being removed? That is our plan, that's our target. And once we removed it and the whole image on the computer turns white, we then know that we've already removed the necessary bone, and we can then proceed to install the prosthesis in the correct position. Now, I will show you the next slide, which is a total knee replacement. All right, so a total knee replacement is a much bigger prosthesis, so we will need a much bigger incision. And instead of using a burr for like in the partial knee replacement, we use a saw because the saw is much faster. And here you can see that the robotic arm is holding onto the saw, and the surgeon is also holding onto the saw. So there is a collaboration between man and machine. So a lot of patients ask, oh, is it the robot just going to do the operation and you're not going to be there? And so we reassure our patients saying that, no, we are going to be there at all times, and we are the ones controlling the movement of the saw. All right. All the robot does is keeps the saw at the correct level and at the correct angle to remove the bone that we have instructed the robot to remove. Okay, and here you can see on the right this green line, okay, and it encircles the boundary of the bone, and that is the haptic boundary of the robot. So this saw blade, cannot go or venture or skive beyond this boundary, no matter how hard the surgeon pushes on the saw blade. So it protects all the surrounding soft tissue from the saw blade. And you will see now the saw is removing the bone as according to the plan, and we get a real-time feedback on the computer system of where that saw blade is, of what bone is being removed. And in a while, you will see that the surgeon is going to try to push his saw blade beyond. He's going to try to push his saw blade beyond that green boundary, and the robot will stop him. Okay, and that's the protection that the robot is able to provide. That is something that conventional instruments are not able to do. So here you can see that the surgeon is going to try to bounce his saw blade and try to go beyond the boundary. You see, he's bouncing it, but the robot is stopping him. So it cannot go beyond the protection of that haptic boundary. One more time, you can see that green line, and the surgeon is going to try to push the saw blade through, all right, but it stops him. So it cannot go beyond that boundary. Okay, so in conclusion, all right, the use of robotic systems in joint replacement is something that is not new, but is seeing a great increase in interest, and it is usually, surgeons usually choose our instruments in order to provide a better surgical outcome for our patients. And the way that robotic systems have helped us to perform our surgeries better is by increasing our surgical accuracy and precision. And in that way, we can avoid implant malposition to improve the outcomes and the longevity and survivorship of our implants. And the robotic systems have demonstrated good reliability and dependability during the surgery and can provide an additional safety during the operation. Thank you. Okay, up next will be Associate Professor Pang Hini, who will share with us enhanced recovery. Professor Pang is our pioneer of our department on enhanced recovery, and a lot of patients have since benefited from this perioperative management, and he is our Chief of Adult Reconstruction and a pioneer not only of enhanced recovery in the knee, but in the hip as well. Without further ado, can I invite Professor Pang to give his talk?
Thank you, Darren, for the kind introduction. And thank you, Patient Liaison Office, for giving us this opportunity to share our experience in hip and knee replacement. And I want to thank all attendees for taking time off your precious Saturday morning to listening to the talks. Right. Today, I wanted to share my experience in our enhanced recovery program after surgery for the hip and knee replacement. A little bit about myself. I was trained in London, Ontario, in Canada in 2012. My subspecialty is that of hip and knee replacements. Special interest in robotic hip and knee replacements. I'm also interested to develop our outpatient hip and knee replacement protocol even more. I do direct anterior hip replacement, and get referred failed knee and hip replacement for revision surgeries. Right? I'm also doing research in wearables and telemedicine. And in my spare time, I like to hike and jog with my family members. Now, osteoarthritis is a very common condition, and it can affect the hips and knees in an estimated 40% of our adult population. Darren has mentioned that in SGH, we see about 5,000 knee osteoarthritis and 500 knee hip osteoarthritis every year. Right? And SGH alone performs about 3,000 total knee replacements. That means about more than 10 cases per day, and 300 total hip replacements every year. Total hip and total knee replacements have been done in SGH for 40 years. Right? They are two of the most successful and rewarding operations for orthopedic surgery. Right? The satisfaction rate is about 95% in certain publications. The average length of stay in the past used to be 4.5 days. Right? So the challenge meeting us is, how do we make such a good operation even better for our patients? Now, the Ministry of Health has been monitoring the outcomes of hip and knee replacements in the public hospitals for a long time. Right? They track the outcomes of these public hospitals, and these outcomes include the length of stay, complications rates, whether the patients get readmitted after the surgery, or whether the patients require blood transfusion rates. So for each outcome, the hospitals are assigned a certain score. Right? The higher the score, the better outcomes in the hospitals. And you can see the SGH in red, we have the highest clinical quality index, that is the best scores among the different hospitals. Right? This means that our outcomes are the best for hip and knee surgery in Singapore among the public hospitals. Okay, and you can see this length of stay distribution across all the different public health institutions, across the different government hospitals. You can see that the tallest bars are usually on the fourth day, which means that most patients tend to get discharged on the third or fourth day in most hospitals. Right? SGH in red has managed to discharge patients on the first day or second day after surgery. This has given us very good outcomes for the length of stay key performance index. Okay. Now, we have shortened our length of stay to 1 or 2 days. And now we are moving on to outpatient surgery. Now, outpatient surgery is not surgery done in the clinic setting. It's actually surgery done in a proper operating theater in hospital, right? With all available services such as physiotherapy and nursing care. So it is for all intents and purposes the same as inpatient surgery. Now, why do we call it outpatient surgery then? Outpatient surgery, otherwise known as day surgery, daycare surgery, or same-day surgery, is surgery that does not require an overnight stay. We feel that our patients undergoing hip and knee replacements can be discharged on a safe day, in a safe and comfortable manner. Okay, right? And if the patients are unable to be discharged, do not worry about being kicked out of hospital. That will never happen. All right? We have a short stay ward. It's a facility that allows for overnight stay with discharge the early morning. Right? In certain cases, for example, patients may feel a bit nausea, a little bit of nausea or dizziness after the surgery, right? Or they may not be able to pass urine so well after the operation, right? So resting overnight in this facility will help the patient recover in time for discharge the next morning, right? Patients are generally not affected by the pain after the operation. Right? Pain is not the main reason for not being able to be discharged on the same day, and that's because our techniques in surgery and anesthesia have improved, right, over time, and generally the patients do not feel much pain after the surgery, although it's a major operation. And why are we moving to outpatient surgery? What's it need for the patients? Okay, now it's a common mindset for patients to think that hip and knee replacement is a major operation that requires a lengthy hospitalization. Okay, our techniques have improved over time, right, in terms of surgery and anesthesia. Okay, and it's true that it's still a major operation, but certainly we don't need to, patients do not need to stay for such a long period of time, right? And if they stay for a shorter period of time, actually they can achieve function earlier, right, when they go back home. Okay, this is a faster recovery in the sense that they can recover better at home in a more familiar environments, in a more comfortable environments, and they will be able to go back into the community faster. Okay, and because of this, right, because they can resume their activities of daily living faster, they have improved satisfaction. Okay, right. With a shorter length of stay, there's also a reduced risk of hospital-acquired infection. Right. In these COVID times, it's important for us not to make our patients stay too long in hospital. We don't want them to catch a hospital infection, right? And in terms of the financial aspects, okay, it saves money for all patients, right? And these savings can be translated to a more sustainable cost for our healthcare system, right? The insurance will be happier and more liberal to cover hospitalization costs from outpatient surgeries, and also the hospitals will be able to charge a lower cost for this hospitalization. So it's a win-win situation for all three parties: the patients, the insurance, and also the hospital. Right? By going for outpatient surgery, you are also helping other patients, right? Because as you know, the waiting time to be hospitalized is quite long, even for the A&E patients. So by going for this outpatient surgery and going on this enhanced recovery package after the hip and knee replacements, you're actually freeing up important resources such as hospital beds for patients who require this on a more urgent basis. Okay, so you're helping these patients to get timely hospital care. Now, how has this evolved over time? We started this enhanced recovery program in 2018 with our master plan for value-driven care. In this master plan, we aim to improve patient satisfaction in the hip and knee replacements by reducing the length of stay and improving outcomes from this package. Okay. And we have identified areas along the whole entire patient journey, from the pre-operative, pre-surgery phase to the surgery phase and post-surgery phase. So at each point, we want to make sure that the patients receive comfortable and safe care, right, so that they can enjoy the journey for the hip and knee replacements. Okay. And what are the key enablers for this program to succeed? Okay. We have make the workflow very efficient for safe and comfortable patient journey in hip and knee replacements. Okay. So you are still receiving the same amount of service, right, that is required for hip and knee replacement. So for patients who were originally staying 3 or 4 days, what we have done is to compress all the services for 3 or 4 days into a single day by making the processes more efficient and also tapping on community networks of physiotherapists and nurses to make sure that you receive these services at home, right? So patients are not shortchanged during by staying just one day. Okay. And we have adopted good surgical techniques such as robotic surgery, as what Darren Prof. Tay has mentioned. We have also very good anesthetists to make sure that pain control is good after the operation. Okay. And this includes having nerve blocks, right, during the operation to make sure that the pain is well controlled after the operation and up to the point of discharge. Right. So these are the three key milestones that were achieved during our operation journey and enhanced recovery after the operation. Right. We have a pre-surgery joint replacement class in which the physiotherapists, the occupational therapists, as well as the specialty nurses will engage our patients and explain to the patients and the family members what to expect after surgery, so that the patients and the family members can prepare their homes for the discharge and also have the confidence to be discharged after the surgery. We have a POD 0, that means a same-day ambulation. Once the anesthesia wears off, we will get our physiotherapists to walk you just a few hours after the operation. Okay, and believe me when I say that most of our patients are able to achieve this after the hip and knee replacement. They will be able to walk around the room with a walking frame on the same day of surgery. Or if the surgery takes place in the evening, maybe you have a rest and the physiotherapist can still see you the next morning, right, to make sure that you walk comfortably. Upon discharge, there'll be home visits by the physiotherapist and the registered nurses, right? So you're not left alone at home, okay? There will be physiotherapists and there will be nurses to make sure that you're doing the exercises properly. The wound care is done properly, right? And this is assessed by the registered nurses, right? Most of our dressing has improved with time. So most surgeons will use absorbable stitches. There's no need to remove the stitches. Most of us would use dressing that do not require regular dressing changes. So this dressing will be waterproof. You can shower over it, and there's no need to change it regularly. So you can basically do your activities of daily living, ignore the dressing, just keep it dry, right? Do the exercises, and you'll come back in about 2 weeks' time, or our nurses will visit you in 2 weeks' time to remove the dressing. Right? There is a minimal care required in taking care of this dressing. Okay, so this is our joint replacement class. Okay, all patients on this enhanced recovery package will go for a joint replacement class before the surgery. In the joint replacement class, we have our specialty nurses who will talk to you, right? They will explain to you once more what the hip and knee replacement is all about, okay? And the pain management after the surgery, right? So there will be definitely pain and a little of swell. There will be pain and swelling after the operation, but with use of with painkillers and regular icing, this pain and swelling are manageable, right? Even after a single day hospitalization. Okay. They will also tell you what the dressing is like. Okay, like I mentioned, most of these dressing are simple to take care of, so you don't need to worry about regular change of dressings, right? They will tell you what to expect, what the red flags will expect. So if the wound gets, for example, wet, right? If there is a discharge there. If there's discharge from the wound, right? You can call these specialty nurses anytime. There's hotline for you to call, and there'll be someone to answer your queries or address your concerns. If necessary, they will bring you back to see the doctor earlier. So you're not left alone at home. And we have your physiotherapist to teach you some of the exercises required after the operation. So you can start doing these exercises so that when you go back home, you're familiar with these exercises, right? Our physiotherapist will also see you at least once after the operation at home, at your home, to make sure that you're doing fine and you're doing the exercises correctly. And the physiotherapist will also teach you how to use the walking aids, walking devices, right? This may be a walking frame or a quad stick or a walking stick. Right? Some of you may prefer crutches. Right? So the therapist will train you in the use of this walking aids to make sure that you are all comfortable and ready to use this upon discharge. We have also the occupational therapist. They may assess your home environment and recommend grab bars in the toilet, right? Anti-slip mats, okay, or a toilet seat elevator. So high toilet seats, okay. So our occupational therapist will prepare your homes for discharge so that the homes will be ready to receive you upon discharge. Okay. They'll also be teaching you how to wear your pants properly, how to carry out your activities of daily living safely, right? Now, most patients will be able to ambulate quite independently at home with the walking frame, as you can see here, right? So after discharge, after a single day of hospitalization, they will be able to walk to the toilets. They will be able to dress themselves properly independently, and most of them can cook simple meals, right? So you don't need to stand for too long to cook yourself an elaborate meal, right? Of course, you can still rely on delivery, right? Or you can use the delivery platforms to deliver meals to you. So cooking or meal delivery is no longer such a issue or major issue or challenge in patients after the hip and knee replacement surgery. Okay, we have our orthopedic diagnostic center. They will be collecting some outcomes from you, right, after the surgery, right? So these outcomes will be used by us to monitor the progress of your operation. Right? They will be doing some measurements just before the operation, and by comparing the outcomes before and after operation, we will know the progress of the surgery, right? Recovery. Okay. So these are some of the patients on the day of surgery after the surgery. Right? So you can see after hip replacement, a few hours after hip replacement, this gentleman can do these steps up and down. All right. And he was discharged on the same day, right? So this is just after a few hours after hip replacement. And this lady, right? Again, a few hours after knee replacement, was walking fairly independently with it, right? That's without any assistive device, right? And she's you can see that both of them are not experiencing much pain, and it's possible to walk just a few hours after the surgery and can be discharged on the day of surgery. Okay. Now, our physiotherapist will see you a few hours after surgery to make sure that you can walk properly and manage a few steps. Okay, so this is a patient with the use of a walking stick, right? So if you have stairs at home, it's also not a contraindication to be discharged on the same day or one day after the operation. Okay, because you can still hold through the railings and using 2 feet to 1 step and climb slowly. All right, it's good to have people to assist you in the stairs, or you can use a walking stick to help you climb the stairs. Right, so it's not you don't need to stay for a longer period of time, even if you have stairs at home. Our physiotherapists and our nurses will see you at home. This is some of the photo footage of what they do at home. Okay, so the therapist will make sure you do these exercises, right? Simple exercises. These are simple exercises that you can manage at home, right? You don't need a physiotherapist to supervise you doing the exercises all the time, right? So can do these simple exercises on your own. Our therapist will see you to make sure that you have been doing these exercises, and they may correct you. Small amendments during the visits, but most patients will be able to cope with these exercises at home without staying in hospital. Okay, so you see, these home visits are also very useful because they will teach you how to maneuver or move around your home, right? They can teach you how to use your toilets properly and how to go out of the homes, right? Because most of us, you're bored at home after a while and you want to go outside, right? So this, our therapists will go to your homes and make sure that you can go outside properly and safely. This is better than doing physiotherapy in hospital, because the hospital is a very artificial setting. It's not an environment that you'll be staying for a long period of time, right? You want to go back home and you want to cope at home, right? You want to return to your daily activities or daily living faster. And some of you may receive this wearable device. Okay, so this device will monitor your movements, the number of steps you take. They will monitor your range of motion. Right? They will monitor your pain score, and they will monitor. It's also possible to upload images of your movement. Okay, so these wearables allow us, surgeons and the nurses, to keep a close watch on your movement. So patients can see what they're doing, how they're doing on the app in their handphone. So there are games for you to encourage you to move the knee, right? Games for you to encourage you to walk more, right? So this is a challenge you can set for yourself so that the recovery will be faster. On our end, the doctors and the nurses can also monitor your condition, right? And make sure that you're not in much pain, make sure you're doing fine in terms of the number of steps you're walking, and in terms of knee bending exercises, right? So we can keep a close watch on you. This is a real-time telemonitoring to make sure you're doing fine. If we feel that you're a bit slow in your recovery, we may call you to find out what's happening, right? We may try to call you if you're in pain to see whether you're taking a medication properly. And we will also check on you if you have any issues with the wound based on the pictures that you have sent us, right? So if necessary, we will ask you to come back early, or we can send our physiotherapists and nurses earlier to your homes to check on you to make sure you are doing fine, right? So this is a device that is very useful and gives us the opportunity, the ability to keep a close watch on you, even though you are discharged after a day of hospitalization. So, in conclusion, hip and knee replacements are very successful operations to improve quality of life in our patients who are suffering from arthritis, right? And most patients can be discharged comfortably and safely after 1 night of hospitalization, right? So I thank you for your kind attention. Next we have Professor Oh Xiao Kit will share with us his a memorable collection of memorable cases from his logbook. Okay, Dr. Goh.
Hello. Hey, thank you very much, Hini, for the kind introduction, and thank you very much to the Hospital Patient Liaison Service for organizing this. I think I've just shared my screen. Okay, right. So let me begin my talk. Sorry. I'm having some difficulty controlling the Zoom. Give me a second. Okay, right. Finally, the slides move. Apologies for that. So, a bit about myself. I've been a doctor since 2001 and been working in this department as a surgeon since 2008. So my practice is largely based in trauma, pelvis and acetabular trauma, as well as hip and knee replacement. Like Darren and Hidi, I also have an interest in robotic surgery and computer navigated surgery for more precision surgery. These are some pictures to show what I do. I'm in the SCDF as well, and I also teach at university. So there's a picture of me with my student taken a couple of weeks ago. So about this talk, my aim is to just share some interesting stories from the many patients I've treated over the past years. So for this, because it involves patient stories and real pictures, so I urge everyone to desist from taking pictures of the slides. So the first patient I want to talk about is that of Ms. Chen. 47-year-old, when I met her, she came to my clinic on a wheelchair because she has pain in both knees for 7 years before she saw me, which means that she has been having knee pain since she's 40 years old. She was on a wheelchair because she could not tolerate the walk from the taxi stand to my clinic in Clinic H. And she works as a bakery retail assistant. So for those of you who have seen us for knee problem, you all could be quite familiar with the appearance of how your knee looked like. So her X-ray shows that both her left knee and right knee are quite worn out. So usually worn knees will happen to people who are a bit older, 50s or 60s, but occasionally we have patients like Ms. Chen who suffer from it earlier. So as a doctor who sees such younger people with arthritis, normally we have to try to work out why is she a bit different. So my first thought was that maybe she was involved in a previous accident, resulting in some bone deformity that make her knee less and straight. If that happens, then of course your knee will not function optimally. But asking her, she has never met with the accident before. If you look at the X-ray, her bones are very straight. This is the imaginary line that we draw in our mind to tell us whether the knee is straight or not. So this line needs to pass through the center of the knee. So in Ms. Chen's case, it is quite straight. Another common reason why younger people get bad arthritis at a younger age is that they may have some hereditary arthritis where the body attacks the joints. This is what I call inflammatory arthritis. So some examples of these are rheumatoid arthritis, ankylosing spondylitis, all very long words. We usually can do some blood tests. We can ask the patient for family history, and such things all turn out to be negative for this patient. In the end, the only thing I can identify is that maybe she's on the heavy side. Her BMI is 31.2. Now, what's BMI? BMI essentially is an estimation of whether a person is overweight or underweight. I was talking to some of my men in my recent in-camp training about 3 weeks ago, and I was surprised that many of them do not know what BMI is. So BMI is an important critical measurement I think everybody should know. Essentially, it takes a weight divided by your height in meters square. And you really want to aim, as Asians, we really want to aim our BMI to be between 18.5 to 22.9. A high BM can lead to a lot of problems. I've seen patients and friends having problems. So I have a friend with BMI of 35 and she's only 30, and she's in her 30s and she has severe high blood pressure, needing medication. And high blood pressure is not good. It can lead to heart attack or stroke. These are all very major problems. Orthopedic wise, it can also lead to premature wearing of the joints. So it's a bit like if a car, I always tell my patient, imagine you're a car and you put a lot of people in a car, your engine will wear out faster, your tire will wear out faster. So all these are not very good. So problems, as I think Professor Tay had mentioned earlier, younger people having a total knee replacement has problems. Younger people tend to be more energetic, they walk around more, they go hiking, whatnot. So all these can lead to shorter longevity of the implants. This means that there's a higher likelihood that the patient will need another operation in the future. Having an operation done again is more challenging because that will mean that there'll be less bone available to redo the surgery. When I met this patient, it was probably 7 to 8 years ago or 10 years ago. I cannot remember. It was a long time ago. So in those days, our mantra was that total knee, total hip should not be done in patients less than 60 years old. And this patient was only 47 when she saw me. That this patient is also not suitable for knee realignment surgery, as her knee was quite straight to begin with. Now, many patients have been asking me recently in my clinic, "What, doctor, can I avoid knee replacement? I hear that you can do operation to straighten the leg so that you can avoid metal in the knee." So I thought I just include this slide. So this X-ray is another patient. So you can appreciate the knee is bowed and he has pain over the inner side of the thigh. So because of this, because of the bow-leggedness, the pressure of the weight is all centered in the inner part of the knee, leading to premature arthritis in this part. If in such patients, they generally do not have pain on the outer parts of the knee. So these patients will be fantastic for knee realignment surgery. And this patient also in his 40s, and I did a knee replacement for his father, so he ended up seeing me. So for him, I told him because the knee is crooked, we can do operation to straighten your leg. So this is what I did for the other patient. Now, but this patient is not suitable for this 47-year-old lady that I was talking about because her knee is straight to begin with, and she has arthritis all over the knee. So I was quite reluctant to do the operation when I first met her because, like I said, she's young. And so I asked her things like, "Oh, can you change your job? Can you do a desk mount job? Can you ask your boss to be a cashier and not do any more things?" But sometimes in life, you really need to be able to do your work to earn a living. So this is what she told me, right? So so after considering her viewpoints, yes, I did a bilateral both sides knee replacement for her in 3 hours, and the knee is straighter. And she went home after 5 days. This was before Dr. Pang came on board to introduce the one day or 2 day stay, a shortened hospitalization stay for such surgery. So she went home after 5 days. And I saw her every year for 5 years, till about 4 years ago. I think she has not been to hospital because of COVID fears. But I remember running into her in a shop because it turns out that one of the jobs was in the bakery near where I stay in Hougang. So that was a happy reunion. So let's go on to the next patient. So as I mentioned before, I'm also a trauma surgeon. So I'm going to talk about this 32-year-old gentleman. So this is a motorcyclist who had a head-on collision with the side of a car. She was actually flung and found 2 meters from the motorbike. Thankfully, the helmet is intact. This is not the video of this particular patient. But anyway, the motorcyclist in this video is also my patient, and he'll probably be mentioned in another talk. But the mechanism is similar, right? Typically at a cross junction, the straight going vehicle goes straight, and then the one making the right turn will get hit on the side. So for those of you who drive, do be careful, especially with the proliferation of cyclists and personal mobility devices. These are often very fast compared to normal walking pedestrians. So please be careful when you have to make a right turn and look at the human crossing the road carefully. This is somewhat difficult if you are older and you have a sore neck, and you'll find it harder to check blind spot. This is something that I wouldn't realize if I'm 10, 20 years. Those of you who are my age or older, you know what I meant, right? So just be careful. Now, helmet. Helmet is something quite close to my heart. Where I studied last time as an undergraduate, cycling is a very big thing. So all of us cycle to school, to our lecture theaters. So when I went to this university in 1995, I remember having to study this paper for my exam. So this paper is written by one of my professors in the university. So this statistic it's a stark reminder why helmet is important, because in this cohort of 1,000 patients who presented to the A&E in Cambridge Hospital, those of them who wear helmets have a much lower chance of getting a head or brain injury. Head and brain injury can be terrible. It is not just a headache. You can have bleeding, and I've seen patients who end up having completely disabled due to head injury. So as we promote healthier lifestyle, people are getting on their bikes more, even children. So please remind your loved one to wear helmet. This can be life-saving. So anyway, back to this gentleman. His helmet is intact. He didn't have much of a head injury, which is a good thing. His main problem is that of a right hip injury. So his right hip, not the left hip, I hope you can see my cursor. His left hip is okay. His right hip looks completely deranged. I have a CT scan here, which show you what his right hip is, reconstructed from the CT scan. It shows that the head of the hip is completely broken into two, and she also had a dislocation of the right hip. Let me go to the next slide. So why is a hip joint important? A hip joint is a ball and socket joint, and it allows a variety of movement, right? So this hip joint, so the ball of this patient is smashed out and the whole ball is out of the socket. Without this hip joint, you can't walk so well, you can't squat so well, you cannot climb stairs. All these things that most of us thankfully take for granted. If you have a hip injury, hip arthritis, you can't do this. So usually when a patient comes to us with hip dislocation and hip fracture, we really have to fix it quickly. This is because the bone, human bone, is alive. So there's blood supply going to the bone, and all these vessels are very fragile. If the hip is out, if the bone is in a different position, all these vessels, you can imagine, will be torn, will be stretched, and the blood will no longer be able to reach the hip joints, and you will end up with the death of the bone. If the bone die, it is not like cement where it will just stay the same. Bone is metabolically very, very active. It needs to repair itself all the time. If this process is interrupted because of the lack of blood supply, the bone will die and bone will collapse. This patient, unfortunately, when he came to us, can you imagine you are flung 2 meters from bike at high speed accident, you are likely to incur many other injuries. So I often see patients with bleeding in the lung, bleeding in the abdomen. When these happen, of course, these injuries will take precedence from bony injury, because if you have a lot of bleeding, you need to stop it first. And after you stop it surgically, this is not done by me, this is done by my general surgical colleagues in the hospital. So after that, we'll have to stabilize the patient, top up the blood, and let the body recover a bit. If we charge in with another major non-life-saving surgery, the patient will have difficulty. The patient's life can be at great risk because the patient can be overwhelmed by severe inflammation. So it took about a week plus before the patient was fit for orthopedic surgery. So he was very young. He was only in his 30s. So instead of trying to fix a bone, we decided that we should just do a total hip replacement for him. He came about the time when we just received this robot that was mentioned by the earlier two speakers. This is the Macro Robotic Assisted Surgery System. So so he was one of the first or second case of total hip surgery that I did using this robotic system. And with this robotic system, the surgery is more precise, the positioning is better. So for younger people, it is very critical. I really want this implant to last him for a long time. Because in his 30s, the typical lifespan of a human being in Singapore is 85, thanks to our excellent healthcare. I also did, instead of the normal metal on plastic configuration, we deliberately choose a ceramic implant for him. Ceramic is much harder than metal. It is a lot smoother, so this will reduce the amount of wear. Everything in this world will undergo wear and tear. So when you walk, there's a friction between the head and the socket. And if we can use using modern biomaterial to keep the friction as low as possible, then the wear and tear will be less. And so this is what I did for him. So this is ceramic, the orange. It's supposed to be pink, but I think it came out orange. Okay, so this is what we did for him, and thankfully he recovered well. I also gave him a lot of road safety advice after the accident. Right, the next gentleman I want to talk about is the 62-year-old gentleman. There's a bit of similarity between this and the younger gentleman. So this gentleman met with an accident 20, 30 years ago before he met me. He had a hip dislocation, and it was told that he did not require surgery. These things can happen. Sometimes the hip just come out, but there's nothing broken. And so sometimes we doctors would just pull it back and that's it, and recovered well. He recovered to an extent that he could play some sports, but subsequently, over the years, he became gradually troubled by backache and left hip pain. So when I met him, he strikes me because he walks in a unusual way, because he would bend his back, and his X-ray shows that his back is crooked like this, right? You need to be, normally it's straight, but this is what I call a scoliosis. And at the corner of the X-ray, we could spy that his left hip looks damaged. Okay, so the reason, and notice that this is a pelvic bone, his pelvic bone is also tilted to one side. Okay, so the reason why his pelvis is tilted like this is because of the severe damage in the left hip. This is what we call avascular necrosis. This is what I alluded to. Because of the dislocation, the blood vessels in the head die, and because of that, the head gradually die, and you have severe arthritis due to collapse of the head. So because of this condition, we often take the ability to open, some people are so flexible they can do a split, right? Most of us cannot. But that maneuver is what we call abduction. So this gentleman cannot do any abduction. You cannot open the leg at all. Instead, his leg is fixed in the inner configuration. So if the leg, instead of being able to open, it actually closes up beyond normal. So because of this, he had to wear shoes that's thicker on that side, because when you do that, your leg will be shorter on the left side. So because of this, his spine will have to be crooked, because if he doesn't bend his back this way, his head will be tilted now. So most of us will not do that, because our brain has clever mechanism to correct so that our vision, so that our world is level. If you walk around like this, you will find it very weird. So this is what I call compensatory curving of the spine, or secondary scoliosis. So this is like Sherlock Holmes. We need to find out what's the root cause of the problem and try to attack the problem. If we attack the back, obviously that's a wrong thing to attack, right? You really don't want to do operation to straighten the spine, because that would mean that his world will be forever crooked. So anyway, for him, he had a very, very severe arthritis, and I have a line here to show you what I meant when the pelvis is tilted. So the root cause of the problem is a hip. So we did a hip replacement for him, total hip. And after this, he's able to open the leg more than before. So because of that, his back pain has improved, and his pelvis is more level, which is what we desire, the desired outcome. Okay. The next patient. Right. So the next patient is really very memorable. Singapore, we are a very, very safe country. I never seen bomb blast. The only bomb blast I saw was as a BMT recruit where I threw a hand grenade. So that was the highlight of the BMT. So this gentleman, he was involved in this a bomb blast. So it's really, really unfortunate incident. In that accident, over 400 people died, and And when you have an incident with so many casualties, the number of injured will be several times higher, right? Probably like thousands of people who has various injury. So these are his X-ray to show his injury. His injury is mainly in the legs, both his legs. He has broken on the left side, he has broken 2 bones. On the right side, he broken 1 bone and foot and ankle. He was airlifted to Singapore after having been preliminarily stabilized in the local hospital, but unfortunately the hospital was overwhelmed due to the sheer number of casualties due to this incident. So he came to see us. There's a sad look in everyone's face, but he was grateful that he's able to come here and seek treatment. So for him, because he needs so many bones are broken. So if we were to fix 1 bone at a time, it would take an inordinate duration of operation, right? 10 hours or so. So I assembled a team of colleagues to do the surgery together. So it so happened that when he was ready for surgery, there's a day holiday. So we got special permission, open a special OT to treat this patient. We got 2 senior consultants, 2 consultants, and so if you all know our department, there's Prof. Tamang Hong, he's a very senior doctor. He was once my teacher a long time ago. There's Nicholas, our foot and ankle surgeon, Dr. Henry, who is a tumor surgeon, and I got Dr. So Chaivik, anesthetist, who is very thankful to him to be able to support us on the holiday. So because many of us, we are able to tackle various injuries at the same time. And so I thought I created this to illustrate what we did. So you can see that we put in 1, 2, 3, 4, 5 metal plates. So of these bones, there are 3 major bones, all broken. And these fractures are not simple fractures. They are very smashed up because it's a bone blast injury. It's not a simple break. It's broken and there's a lot of, some of the bone is a bit shattered as well. Okay, this is the ill effect of the bone. You can see there are some beads there. So these are something that I've never seen in my career. These are bone blast beads. The beads, metal beads from the bomb to make the bomb more devastating. So this is what we did for him. So after the operation, he has not walked for about a few weeks by the time he had the operation. And after the operation, he also had to undergo intensive physiotherapy to regain his strength. And that's him. I think he was in Singapore for a few months, and before he flew off, he came to thank us. And yeah, so I'm glad that he's able to walk quite well now. But do not forget, all right, over 400 people died in this accident. And actually, I said there was a sad look on their face. One of the child, I think he was about 10 years old, also died this tragedy. If this were to happen here, our system will be overwhelmed, just as COVID has overwhelmed healthcare system worldwide. So I mean, while we are a safe country, but when I talk about this patient, I normally include these newspaper cutting because we need to be constantly vigilant because such things can happen to us as well if you are not careful. Right? These are all from Straits Times. Once in a while, we have these kind of things happening. We really should not take this for granted. People like come here because we are safe, but we need to do our part to be safe. There's things that we do at the national and government levels. Dr. Tay, Dr. Pang are in SAF, I'm in SCDF. So we do our national duties once a year, probably about 1 to 2 weeks. Individually, I think we also have it's important for us to treasure this peace and stability, right? We need to see, look out for one another, right? We need to watch what we see on our devices and what our children see on computers and handphones, right? Yeah, this is what I do. I was just doing this about 2 or 3 weeks ago. Spent 2 weeks in a CDF. These are the things we are trained for. We train to evacuate patients who are trapped by falling rubble. And those of you, the only main building collapse would be things like Hotel New World, which happened when I was in primary school. If you're older than me, you'll probably recall these things. So if you look at the war news from Ukraine, you'll see that at one go, many buildings can collapse, right? Or in a bomb blast situation. So if this happens, then that's what these emergency services are for, to train, to respond to these emergencies. Hopefully, we'll just do exercise without having to be activated. So, in summary, this is the last slide now. So limb problems can lead to disability that can severely impact on people's life. This is very real because it can affect people's job, personal life, education. Some disabilities can be avoided with healthy lifestyle and avoidance of dangerous habits. So, for example, we jog, we need to watch out for dangerous situations with cycle and driving, especially. Watch out for yourself and spare thoughts for fellow road users and operate your vehicles in a safe way. Try not to rush. We, of course, need to have a good healthcare resources hospital, which is not too full, to be able to execute our roles well. Orthopedic surgeons, we work to mitigate these disabilities, and we can do so with the availability of good modern implants and techniques that are constantly improving. Okay, so this is my last slide. So we are happy to take any questions after this talk. Thank you very much. Okay, now we are moving on to Q&A. So I know many of you has paid really close attention to all the three speakers and have put in many questions for us to answer. So some questions will be replied live. So can I get Pili to turn on the video as well? Okay, so our back-end administrator will be helping us to put up the question for us to answer.
Yeah, so maybe I'll take the first question. All right. So it was asked: is it common that a joint replacement will only last 10 to 15 years? And that really depends on the number one, the quality of the surgery performed. But let's say that all being equal, you got a proper surgery done. Then it would also depend on your age, right? Because your age is a surrogate for your how many more years you have to go and your physical activity levels. So a younger person would be expected to be more active than an older patient, and that's just a generalization. But if we were to operate on, say, a 45-year-old as opposed to a 70-year-old, then certainly the 70-year-old patient would be expected to have his implants last really long, be it 15, even 20 years and beyond. However, for a 45-year-old, we hope that our surgeries are able to provide them that ability to carry out their physical activity. We want them to use their joints, and so perhaps it may last shorter, right? So it may last maybe 15 years, maybe even more. It is difficult to really give you an accurate answer because a lot of these studies were done with implants that were put in 20, 25 years ago, and many of these implants are no longer being used, and our techniques, our materials for our implants and the implant design themselves are all much better than what was previously available. So the current literature for knee replacements when we look at big data, it appears that it's a very successful operation, very good track records in survivorship. Many of them last, 90% of implants can last beyond even 20 years. Certainly about the patient joint variability, that perhaps is something that we are still exploring. We are hoping that by appreciating that, we can give patients a knee that feels more natural to them, right? Something that behaves within their soft tissue more like their original knee. And with regards to osteoporosis, we deal with osteoporosis on a routine, regular basis. So it is not something that it is unexpected. Most of our patients, I would say, have osteoporosis. And so we have numerous techniques to deal with it. So the effectiveness of joint replacement should not be compromised based on that. Okay, with regards to after knee replacement, how long will it take to completely recover? So most of the time, patients will need a walking aid for anywhere from about 2 to 4 weeks. Usually they would start off with a frame. Sometimes they will then be progressed depending on how they recover to a walking stick. Most of the patients do not need a walking aid from anywhere from 2 weeks to 4 weeks after surgery. With regards to walking normal, I would say it takes about 2 to 3 months on average, and that would include walking on flat ground and climbing upstairs. With regards to descending stairs or going down the steps, that will take a bit longer because that really requires a greater amount of flexibility in the knee and a greater amount of strength in the knee muscles. So that may take a little bit longer. Usually I would tell my patients you can expect sometime like 6 to 9 months following the surgery. Is robotic surgery offered to all TKR? Yes. At the moment, they should be covered under insurance for both outpatient and inpatient surgeries. So for primary osteoarthritis, the most common tests that we use are radiographs. So we do an X-ray and usually we're able to make a diagnosis. There are certain specific types of osteoarthritis which result from systemic illnesses such as rheumatoid arthritis or systemic lupus, some inflammatory joint arthritis. Right? So those may require certain blood tests. We will look for inflammation in the body, and if we do find that these patients are suffering from something beyond just the routine wear and tear, then we will also usually refer them to see our rheumatology colleagues who deal with autoimmune diseases and inflammation within the body that, as part of the disease process, have caused joint degeneration.
Hi. So this question is for me. The audience who asked this, I think he has some background knowledge. He even knows the terms of TFNA dynamic hip screw. So essentially, when we think that the head of the thigh bone is not likely to survive, then we will consider replacing the head. Okay, so this is what we call a hip replacement surgery. It can be a hemiarthroplasty, meaning that we change half the hip joint, or we change all the entire hip joint, the ball and the socket. So this is called a total hip replacement. TFNA dynamic hip screws, these are basically technical terms. These refer to devices that we use to repair the bone if we think that the bone is still viable. That means we think that the blood vessels are not likely to be disrupted. So we can fix it and the hip will still survive. So if you remember my talk, my patient who had this hip dislocation and the hip subsequently died. So So if a fracture that we think that is likely to lead to death of the head, then we will probably do a hip replacement. I hope this will answer the question. All right, so this is a very good question. So the hip joints is a ball and socket. I don't have a skeleton here. So the reason why surgeons typically tell you not to do certain maneuvers is that you do not want the head to be moved such that it will actually come out of the socket. Now, the good news is the hip joints will become more and more stable as the time go by, because besides the bone, there's also layers of muscles and soft tissue that will form a very tight envelope around the bone. So this will make the hip joint more and more stable over time. So usually most people after a while, they can bend more than 90 degrees. They can cross the leg, but do it carefully. I always tell patients it's like, the more dangerous maneuver you do, it will increase the risk of something bad happening. So it's like you go to Grand Canyon, some people wouldn't want to stand so close to the edge in case you'll fall down, right? For me, I tend to stand a bit far away, so I'm a bit more careful. So it's not true that you cannot do this, but do it carefully and not do it and do not be too clumsy, and this will reduce the risk of hip dislocation. So jogging. I jog as well. So does I'm sure Darren and Heaney also jog. It will be dangerous if you jog in the night wearing black color overall and have nothing shiny on you, and the cars cannot spot you. I jog and I drive, so I know how dangerous it is for people to make themselves so invisible on the road if they are all wearing black. But I think the patient who put the audience who posts this is also probably referring to whether jogging too much will lead to hip or knee arthritis. It's a difficult question because, frankly speaking, you do need to exercise. If you exercise, you do some exercises, actually, you promote your cartilage health, you'll make your cartilage more healthy. But you will overdo it, of course, it can cause some damage as well. And it is impossible for doctors to tell you exactly how many kilometers you can jog a week before you get arthritis, because different human bodies is just built differently. Take for example, if you are very heavy to begin with and you jog a lot, then of course you can lead to overload as well. So we always tell patients to listen to our body with exercise. If you do some exercise and you get pain, then be careful. Maybe rest a bit, space out your exercise, or exercise different part of your body. Like sometimes you exercise your arms, sometimes you exercise your legs, sometimes you go swimming, sometimes you go jogging. This is how you can prevent injury to yourself. I speak this from my personal experience as well. Okay, yeah, I hope this answers your question. Thank you.
Okay, hello. So this is question, what is the successful rate of total hip replacement? Total hip replacement is actually very successful. We quote a success rate of 95%. 95% of patients will feel better after hip replacement. It's actually one of the two most successful procedures in surgery, the other being cataracts, right? Because in cataracts, you're blind, and after a cataract surgery, you can actually see again. Right, so total hip replacement is like that, right? You have a very bad hip pain before the operation. After operation, your hip is like back to normal, right? So your quality of life improves so much. It's almost like being able to see again, right? This is a comparison that we have. Okay. Okay, so why is it that most people are unable to bend or squat totally after knee replacement? It may be because before the operations, their knees were very stiff to begin with, right? So after a knee replacement, their movements may improve about 10 to 20%, but because they have been very stiff to begin with, right, they may not be able to achieve a full range of motion, right? The other reason, common reason, is because they have not been doing their exercises after the operation. It's important to do the exercises after the operation. Like I mentioned, these exercises are very simple. It's important to do it daily, 2 or 3 times a day, to make sure the knee loosens up and regains the movement, right? The materials are mostly the same for our knee and hip replacement, so they will not affect the outcomes generally, right? We use very good implants with good track records and good registry results, so do not worry about the type of implants that we use. These are all certified, safe, and successful implants. Yes, it's common to experience numbness over both knees, over the skin after the operation, right? This will not affect the walking, and this is because the nerves that innervate the skin, the sensation, they are cut during the operation, right? So it's like most of you may feel some numbness over a scar. This is exactly what you feel. If you don't touch those areas, you will not be able to feel the numbness. Okay, next. Any questions? When is a hip surgery necessary? A hip surgery may be necessary if the patient has severe pain that affects the walking or are not able to walk. In general, if you have pain disturbing your sleep at night, if you have pain that affects your walking and you need to rely on more of a walking frame or walking stick, or you need to be on a wheelchair when you go out into the community, or it affects your activities of daily living, like you can no longer travel, you can no longer go for walks with your family, you can no longer do the things that you like. This is a time when you may want to consider replacement surgery for your hip osteoarthritis. Okay, what are possible risks involved for a 74-year-old male? 90 kilograms, mild stroke, or medications with high blood pressure and blood thinners. Okay, so I would say the risk involved will be related to the stroke itself and also the heart. So before the operation, we would send you to see a heart specialist or a stroke specialist to make sure that your heart problems are not too severe and your stroke, you recover fully from a stroke. Okay, so it's still possible for this patient to undergo a hip replacement once they cleared their heart and stroke specialists. The risk of deep vein thrombosis after hip replacement, knee replacement, is around 1% for asymptomatic ones, right? Up to 20% may have a little bit of blood clots in the legs, but these are generally not symptomatic. That means they don't cause any signs or symptoms. In the rare 1%, when they have very big clots, this may cause symptoms like swelling, pain, weakness, right? And this is the time when we need to treat the blood clots. All patients will be put on blood thinners after operation to prevent the blood clots. And despite all our best efforts, blood clots do occur in some patients, rarer in our Asian populations, more so in the Western population, right? In the event that these blood clots do occur, we will have to treat them with blood thinners. Okay, next please. Any more questions? Yes, the joint replacement class, all charges are included in this package. We have one fixed price package for our joint replacement, for ERAS program, for enhanced recovery after surgery program. So it's all inclusive, right? You can get the charges from our patients liaison office. Okay, next slide. Okay.
Okay, thanks for this question. 33 years old, arthritis at 3. Okay. It is difficult to answer this kind of specific question specific to the individual over such chat. It is important that because we need to see this patient because to examine the patient, because a consult, we need to see the patient, understand more, and do more investigation. The key thing is for us to isolate where the pain is, and so that we will know exactly what surgery can be done. So this patient may want to get an appointment to see us. Being 42 years old, I also mentioned in my talk, we generally are quite reluctant to do any form of replacement surgery unless we think that it will really help the patient's life in terms of jobs and many other things. So I did one operation like this for my patient who was 47 in my talk. Yeah, but do come and see us for an opinion. Yeah, thank you.
Hi, Dr. Pang. I think we have a question for you.
Okay, so now chronic pain after a knee replacement is not so common. Studies have shown that it's between 10 to 20%, right? In most cases, what we want to rule out is an infection. Right? This is the first thing we want to exclude. We'll do tests to make sure that the knee is not infected. Okay, but generally, you have to seek help from your primary doctor. If not, you can come to us, right, the specialist, to assess why the knee is still painful. It's common to have a little bit of knee pain up to a year after the surgery as the knee takes to recover. After a year, there's an occasional aches and pains, but generally the pain should not be so bad as to affect the quality of life, should not be so bad as to affect your sleep. Okay, so if the pain is so bad, so chronic, then it's important to rule out infection, right? The other thing to rule out is whether there is any movements in the knee implants, right? Whether the knee implants has loosened, early loosening, right? May also cause chronic pain. Aside from that, unstable instability, that means if the knee is not balanced properly, or there is an injury to your ligaments, this may also lead to chronic pain. So in most cases, in most knee replacements, the pain gets better up to a year. But in 10 to 20% of cases, when it does not get better, it's important to seek a specialist to find out why it does not improve. Okay, so important to do physiotherapy after the knee replacement, because with physiotherapy you will be less stiffness and you will have muscle strength. Okay, so it's important once you are done the proper physiotherapy and the pain is still there, it's important to, it will be necessary to get your specialist to have a look. Okay. Next slide, please.
Hi, Prof. This is the last question for today. Yeah.
Okay, so if I require knee replacements for both legs, is it advisable? All right, so there are certain scenarios where we would prefer to do both knees in one single operation. Right. So the first scenario, and this is related to the deformity of your knees, is that if you have severe deformity, meaning that you're very bow-legged in both legs, then the consequence of just doing one side first is that that leg will be straightened, and as a result of the surgery, it tends to become longer. So if your deformity before the surgery, if your bow-leggedness is not too severe, then it usually isn't an issue. But if you're very bow-legged and we straighten out only one, then some patients would experience some difficulty walking, normally or naturally or comfortably when one leg is long and straight and the other is still bow-legged. So that's one scenario where we would advise patients to do both knees at a single operation. The other is when patients are very disabled by the pain and they cannot determine which one is hurting them more, or they say that both knees hurt just as bad, and they want to have one surgery at one sitting, one anesthesia, one hospitalization to solve their problem. So this would be when this scenario would be when you would also do bilateral knee replacements at one operation. Most of the time, I would prefer at least to do it in two separate surgeries for two reasons. Number one is that when you do both knees at one go, there is an increased duration of surgery, there is increased blood loss, and that may result in increased complication rates. Number two is that sometimes when you do one side, when that operated side recovers, patients are able to depend more on that knee, and as a result, they put less pressure on the remaining unoperated knee, and that actually improves their condition for the other side as well. With regards to the cost of partial knee replacements and that of full knee replacements, they're generally about the same cost. So that there isn't a significant difference between the entire, amount of hospital bill when you include everything in. They tend to work out to be about the same. What is certainly different is the rate of recovery, and a partial knee replacement, when it's done through a smaller incision with less blood loss, and patients tend to have less downtime if it is done well, and the patients recover probably about 2 times faster than a full knee replacement. So if you're talking about returning back to work and becoming economically productive, then there is a difference. But in terms of the hospital bill, not so much. Okay, I think that brings us to the end of the webinar. We'd like to thank the panelists for their invaluable insights and their lectures, which I hope all of you have found insightful, beneficial, and we are very happy to have all of you attend this webinar. We hope we've tried our best to answer as many questions as we can, but unfortunately, we were not able to answer each and every one of them, as there were about 100 over questions. But we again thank you for spending your Saturday morning. Again, I'd like to thank the Patient Liaison Service Department. And again, they are running an entire series of different lectures from different specialties. And if you're interested, please, we hope to see you all in attendance in the upcoming webinars. Thank you and have a wonderful weekend. Stay safe.